I'm going to turn the mic over to Justine for just a moment. Justine has a day job, although for the last 2 years you wouldn't have known it because it's been surgery 24/7. But she is the editor of the Lancet Diabetes and Endocrinology, and she, mostly because of her doing and that she wanted to have a commission on global surgery, started out as our editor and became so involved that now she's one of the authors on the commission itself. She really helped guide us a tremendous amount. We owe a great deal to you. She is going to talk briefly to give you a little background about the Lancet Commission process itself. So Justine, I'll turn it over to you.
Thanks, John, and good morning, everybody in Boston. It's wonderful to be here. I'll remove that photo of me. You can already see me. So, you may wonder why somebody who is the editor of a Diabetes and Endocrinology journal is here speaking with you today. Well, I have a professional interest in surgery. John actually thinks I'm a closet surgeon. And recently, for those of you who can get close enough to see the scars, you'll see I've been falling off horses and breaking bones, so I've developed a personal interest in surgery too. Anyway, I'm here to tell you about why the Lancet got involved. And to do that, I'll take you back to our founder, this rather smug-looking gentleman here, Thomas Wackley. He founded the Lancet in 1823. He was a rather outspoken and irascible chap. I'm going to make no reference to the current editor at all. And he founded a magazine because he wanted to let the world know about the inequities in healthcare in the UK at the time. So he said he founded the Lancet because it could be an arched window to let in the light or a surgical instrument to cut out the dross, and he intended to use it in both of those senses. Now, he was interested in the UK, but since then the Lancet has grown to be a more global health-centred journal. What is global health? Well, it was very succinctly defined by Copland et al. And the Lancet in 2009 as being an area for study, research and practice that places a priority on improving health and achieving equity in health for all people worldwide. Now, that's all very good, but in this all-encompassing definition, where was global surgery? Well, for that, I'm going to take you back to Wackley, because Wackley, although he was interested in the UK, was actually a surgeon, and he had a lot to say about surgery, and perhaps since his time we haven't had so much to say. So this is my favourite Wackley quote, where he says, "The Council of the College of Surgeons," this is of England, "remains an irresponsible, unreformed monstrosity in the midst of English institutions, an antediluvian relic of all that is most despotic and revolting, iniquitous and insulting on the face of the earth." Needless to say, we have moved on. We now feel the surgical love, and all of my colleagues are absolutely overwhelmed by this project and the effort that everybody has put into it. So why a commission on global surgery? Well, it was about 2 years ago that I found myself sitting next to Andy and Lars at the Royal College of Surgeons in England conference on surgical frontiers. And we ended up kind of, moaning to each other that there were all of these people and they're all trying to do good things. But there was no coordination, there was no global effort, there was nothing at that conference that, despite all of this effort, was going to put global surgery on the global health agenda. Did a recent Web of Science research, and this is really quick and dirty research, and looking for global health in the titles of papers, and there's over 15,000. You look for the title Global Surgery in Web of Science, you find 320 papers. There is nothing on this subject. There has been not enough interest in this area, despite millions of people dying for want of surgery. So what do we do when we do a commission? What we want to do is actually change global health policy. This is nicked completely from Jeremy Schiffman, if he's around. Thank you, Jeremy. So generating political priorities, says Jeremy, takes ideas, characteristics, political content, and strong actors. So how does a commission feed into these 4 areas? Well, firstly, the most important thing and the best thing that this commission has done is it has come up with powerful ideas. You're going to hear about these from John very shortly. We've defined the extent of the problem and we've framed the problem in the global health arena. We've also come up with solutions to the problem. So we have powerful ideas in this commission. We also, exceedingly importantly, have defined characteristics of the problem that one can monitor. So you can show now what the extent of the problem is, and also we can monitor change as we progress. Unfortunately, we can't do an awful lot about the political context, but the Sustainable Development Goals are still ongoing. We need to get surgery and we need to get procedures into those Sustainable Development Goals. The ink is not yet dry and we need to do this. The World Health Assembly resolution on essential surgery is just going through. That should be passed later this month. So we actually have very fertile ground for this Commission report to grow. Lastly, strong actors. Now, who are those strong actors? Now, I would like to think that that is everybody in this room, everybody who is at London, and all of the people that have made this Commission report possible. The strong actors are us. And what we need to do, and this is exceedingly important, is we need to unite behind the ideas that we have created. There is going to be dissent. What the Commission report has produced is not absolutely concrete. All of our metrics are not absolutely concrete, but they are the best that we feel we can get at the moment. And if we do not unite behind them, if we fragment now, we're going to lose any chance of getting surgery on the global health agenda. That is the most important thing that I can say to you all today. We need advocates on a global scale. We've got G4 Alliance here who are doing that. We need also advocates on a local scale. We need to talk to people in Africa, Asia, South America who can advocate, who can pick up the challenge and run with it. So how do we convince them? Well, we can hug them into submission, as Paul Farmer seems to be doing here, and I think that's a really great way to start. And we can produce a really good, solid Commission report, and that is what we've done. So over to John to tell you more about that. Thank you, John.
I like that, hug them into submission. I haven't used that one before. So Justine already talked to you a bit about the commissions and the background and the fact that the purpose of these is to generate change. So it isn't just to be an academic document, it's to inform and drive policy change. Now, let me tell you how this worked. Justine and Lars and Andy, they met in January of 2013, and they said, gee, it might be nice to have a Lancet Commission on global surgery. Justine went right to this guy's office and said, hey, I think we need a commission on global surgery. And I give him credit for A, recognizing the importance, and B, respecting Justine enough to say, okay, run with it. So that's what happened. Now, we then, months later, met with Richard in London, and he was very clear. He said, this is what you need to do. 1, assess the current situation. 2, I want a few key messages. Not a dozen, not 15. I want 3 or 4 or maybe 5. And I want recommendations, very clear and to stakeholders, so not nebulous. And the last thing he said, which is something that also Jim Kim mentioned in his first video address to us, is indicators or metrics. Jim Kim called them time-bound targets. Both of them felt the same way. How will we know if we are improving if we don't have indicators or metrics? And obviously, it's all focused on the inequities around surgery and bringing about change. So the process. This is January 2014, the 25 original commissioners. We met for the first time, many of us, and there were probably, actually many of you were here then. There were about 100 in total. And we very quickly decided on a vision: universal access to safe, affordable surgical and anesthesia care when needed. And I think that was very important that we defined that very early on, and we were all working towards the same goal. We then met in Sierra Leone in June, right before Ebola really exploded. We then met in Dubai. This was after the 9 reviewers had reviewed the document. We really had to roll up our sleeves. There were literally hundreds of pages of comments and edits, so We worked on that in Dubai. Bellagio was a slightly different type of meeting. So this was gratefully funded by the Rockefeller Foundation. We brought together a different group of commissioners, and the idea was to take what we had done and show it to folks from Ministries of Health, Ministries of Finance, USAID, World Bank, WHO, and say, look, what do you think of this? How does this play? And then what do we do with this? How do we go to Ministries of Health in your region? And how do we implement this? All right, so this was a very important meeting, but slightly different than our prior meetings. And then the other thing I would mention is we made an effort to have a lot of regional meetings because, as I said before, we didn't want this to be an academic document that 25 people put together. We wanted this to be something that everyone felt ownership of. At the end of the day, we had over 110 countries involved, people from, I think it was 111 countries, so I think we got very broad involvement. And this is the document which you have, and it's available free online as well. Now, one other point of clarification. We were very clear early on also in defining what our scope would be, and it's over here. So underserved populations in low and middle income countries. Not that these aren't important, but we just felt that with 25,000 words, we really wanted to do justice to this aspect. The components of health system strengthening in low and middle income countries certainly have positive implications for the rest of global surgery. Outputs. Obviously, we're going to talk most about the report today. Tremendous amount of new research that went into this, and actually we collaborated with 7 different journals. So there will be publications in the Lancet and Lancet Global Health, of course, but Surgery, the Bulletin, British Journal, World Journal, and the American Journal of Obstetrics and Gynecology all will be having articles, abstracts, or our executive summary in them. So it's really wonderful that the community came together, 7 different journals participating with us. Something else that's very new, we have 15 teaching cases which are in the process of being written, and actually tomorrow at Babson College, we're going to have a day where we do a demonstration of 3 of those cases. And the idea behind this was prior commissions had done the report and research and had done a wonderful job of that. This adds something different, a different dimension, an educational foundation. And the reason is, you all have the report right now. That's not something that lends itself readily to education, for example. You're not going to readily take that to a classroom and say, okay, let's open up to page 27 and start discussing that. But these teaching cases are something that can be an ongoing source of education, and not just in business schools, but in schools of public health, in medical schools, hopefully in surgical training programs, in anesthesia training programs. So we're hoping that this lends itself to a new form of education that will continue on, and actually beyond the 15 cases, I'm hoping that that will continue into the future. The report itself, as I said, you have a copy of that. It's free online. I want to show you diagrammatically how we constructed the report. So visually, we broke it up into 4 working groups, and I'll discuss these in a little while. We have key messages at the front of the report, recommendations throughout all the working groups, our key indicators, 6 indicators, which I'll get to at the end. We also have a section on research, and then another unique thing, the National Surgical Plan, which is also in there, and one of your briefing documents has the National Surgical Plan, and I'll discuss that. So what did we find? Well, let's talk about the key messages, the first of which, 5 billion people cannot access safe, timely, affordable surgery. That seems a little bit striking, and some of you probably remember that 2 billion number. And it's interesting because Paul's sitting right here, and he always chafed at that number because he said, look, there's no possible way that only 2 billion people do not have access to surgery. And when you look at the methodology in the past, they looked at just the number of operating theaters. And what you find when you dig a little deeper, this is what I wanted. When you dig a little deeper is that there are a number of things that are involved in getting a patient to the operating room safely and in a timely way. So first they have to get there. If they're 100 miles away and they have no means of transportation, it's really hard to get there. What about if they show up and there's no electricity, there's no oxygen, there's no blood, there's no capacity for that system to provide care? What if it's not safe? No pulse oxes, there's not a trained anesthesiologist. And then lastly, if they can jump over all of these hurdles, what if it's not affordable? What if the cost of getting your humerus fracture fixed, as Justine alluded to, what if that's 3 times your annual salary? Then it doesn't matter that you got there, you still can't have it done. So when you look at this type of a decision tree, it's not just the 2 million. It's actually 5 billion people who don't have the type of surgical access that you and I have. And this just describes it a different way. It's the joint probability, which I'm sure you all love this equation, the joint probability of all these things happening at the same time. Now, when you look at that on a map, you can see the darker red countries are the countries that have very poor true access to surgery in terms of it being timely, affordable, safe, and that there's the capacity there. And in some areas of the world, 97, 98, 99% of the population really does not have the same type of access that you and I have. I'm going to discuss this with you a little later, the concept of the 3 delays, and this is the construct we use to explain why is it that patients can't get care. They have problems for seeking care, reaching care, and receiving care, and that's something that came out of one of our working groups that I'll go over later. Key message number 2, 143 million patients need a surgical procedure. That's a huge number, so 300 and some million procedures are done every year, and 143 million additional procedures are needed. 1/3 of the world's population receives 6.3% of the procedures done globally. That's an amazing statistic. This is a bit of an eye chart, but this is where it came from, and this is John Rose and Tom Weiser did this. What they did conceptually is they looked at the burden of disease in various countries, theoretically how many procedures would need to be done, and then they said how many are done. And you can see by region, there are some countries that are meeting the need, and then other countries grotesquely are not meeting the need. And just to provide a bare minimum number of procedures would be 143 million. All right, and this looks at the operations per 100,000 people in 2004, and you notice what's happened between 2004 and 2012. Health outcomes. I want to show something here that we did. We looked at procedures per 100,000 and graphed that against different health outcomes, in this case, life expectancy. Now you notice there's a bit of a tipping point around 5,000 cases. Now I'm not trying to convince you that Y is a function of X, so more surgery is not necessarily better, all right? But you notice something fundamentally changes in a healthcare system when you can provide around 5,000 or 6,000 procedures. Look at the outcomes in this group below, say 5 or 6, and look at the outcomes above. Now this is why we use that number of 5,000 for our modeling, all right? And to be honest, in 5 or so years as we're collecting more data, maybe we'll find that it's 6,500 or 7,000 or 5,200. That's not the point. It's that something fundamentally changes when you have a system that can provide the basic surgical care. Now we looked at that in a number of different ways to kind of check that. So we had our modeling team look at this in terms of median surgical rates associated with life expectancy, with MMR, et cetera. And all of the ways we looked at that seemed to center around 5,000. Now this shows you what countries have to scale up the most. So you look at these countries in red. They're a far cry from that 5,000. All right, we're going to need dramatic scale up in these countries. Key message number 3, 33 million people face catastrophic expense. Now that's for direct healthcare expenditures. If you add indirect, it's 48. It's 81 million people. That's more people than there are in the UK that face catastrophic expense due to surgical procedures. Why is that? Well, part of the reason is that about 3 billion people live on $2.50 a day. So if you need a humerus fracture repair and it's $200, that's likely going to be out of your range, all right? What's happened historically? Well, historically, there's not been a prioritization of financial risk protection in these countries. There's been a heavy reliance on out-of-pocket payments. Surgery historically has not been included in basic delivery packages. And interestingly, it's not tracked. The financial inputs to surgery have not been tracked, and I'll show you that a little bit more. So the bottom line is, around the world right now, and this is some work that Mark Schreim did, about 25% of the people who look for surgery, who seek surgical care, will be impoverished or experience catastrophic expense. Key message 4, investing in surgery is affordable and save lives. Now, if you pool all the ministers of health, or actually finance, and you go to them and say, you know what, the cost is going to be $350 billion. That's going to be a little intimidating to them. Until you look at this number, which is the return, $12.3 trillion of potential GDP return on that investment. So I think this speaks to who your audience is. Your audience for or if you're speaking to ministries of health, it's different than ministries of finance. This type of return on investment argument is what we need to use for ministries of finance. This just shows you the cumulative GDP drain of $12 trillion between now and 2030. In our last meeting, one of our Bellagio commissioners had an interesting thought. He said, look, instead of thinking about development assistance for health, funding surgery is really health assistance for development. You're promoting economic development by investing in surgery. Key message 5, and this is something that Jim Kim said in his first address to us in January of 2014, that surgery is an indivisible, indispensable part of healthcare. That's quite a statement. It's not separate. We're not competing. It's not surgery versus infectious disease, that it's an indivisible, indispensable part of healthcare delivery. Now, why is that, and why should it be? Upwards of a third of human disease involves surgery or involves surgical decision-making. This is some work that John Rose and Steve Bickler did. They looked at the different global burden of disease categories and looked at the frequency of surgical intervention. Just intervention, not even decision-making. This was just intervention. And every GBD category can require surgical intervention. Now, I would argue this undercalls it because there are cases that don't require surgery, but you need someone with surgical decision-making ability to make that call. So I think this even undercalls the importance of that. No matter how you look at surgery, or no matter how you look at human disease, surgery is important, whether it's life course, a burden approach, level of care from prevention through tertiary or palliative, surgery is involved. And also, what we've come to find out through this whole process is it's necessary for a number of different aspects. So universal health care, sustainable development goals, ending poverty, resilient healthcare systems. Paul will talk later, and I think one of the things he'll say is that without having an appropriate surgical foundation, a surgical system, healthcare systems are not resilient, and perturbations can really be destructive without that type of infrastructure. And all health movements. So again, it's not surgery versus other health movements, it's surgery with everyone. So let me switch gears a little bit. I want to talk about the working groups. Those were the 5 key messages, and I want to give you some insights into the working groups. So the HDM group, or the workforce group, looked at the workforce, and I want to show you some interesting findings here. So we looked at SAO provider densities, so surgeons, anesthesiologists, and obstetricians per 100,000. And again, we plotted this against different health outcomes, and we found something interesting. Above 40, health outcomes didn't seem to change much. And below 20, they declined tremendously. We noticed something's happening between roughly 20 and 40. All right? And again, we're not saying that every country needs to have 23.5 SAO providers per 100,000, but something fundamentally shifts in a healthcare delivery system when you have an appropriate number of surgeons, anesthesiologists, and obstetricians. So that's why we use this range for our modeling. It's a big task, so getting from where we are now to, say, 20 per 100,000, it's a big ask in the next 15 years. And to get to 40, also a big ask. What we looked at in terms of getting to 20 is, you can see by the colors here, there are some countries that need 18, 19 or so providers per 100,000. So workforce scale up for certain countries is going to be a very important issue. Healthcare delivery and management. We borrowed a framework called the 3 delays from the maternal health world, which looks at delay in seeking care, reaching care, and receiving care. And you'll notice in the report that this is a kind of a conceptual framework. So why do patients delay in seeking care? And there are a whole list of reasons and solutions. What causes them to have delays in reaching care? What are the issues, problems, and solutions? And the same in terms of receiving care. And one of the things that we really zeroed in on, and I think this is an important concept, is you'll see mention of the bellwether procedures in this working group. And we talk about cesarean delivery, treatment of open fractures, and laparotomies. Now, historically, people have talked about, are there 15 or 18 or 25 or 35 procedures that we should be doing? And we got a little bit away from that by saying that maybe the concept is more of platforms and capabilities. And what we found in looking at hospitals with the WHO, hospitals that could safely provide these 3 types of procedures had economies of scale and scope that other hospitals did not. And let me show you what I mean by that. So the blue bar, these are hospitals that do provide cesarean deliveries. And you can see the red are hospitals that don't. So the hospitals that do have a much broader capability. They can reliably do things that other hospitals can't. If you have district level hospitals that can provide laparotomies, they're more likely to be able to provide a broader range, and the same for orthopedic procedures. Now, why is that? Because if you're a minister of health and you invest in these capabilities, you invest in the people, the nursing care, the theaters, the instruments, and you have all this set up for you, the marginal cost or the marginal difficulty of moving to maybe a slightly different procedure or more of the same procedures is really quite small. Finance and economics. And this is what underpinned the fact that investing in surgery is affordable, saves lives, and promotes economic growth. And Gavin Yamey is going to go into more detail later. But there are 2 major arguments. The first is around an economic case, and the second is around the financing issues for surgery. Let me talk to you about the economic case. This is a pretty substantial number. Upwards of 2% of GDP or maybe I should phrase that a different way, surgical disease is a 2% drag on low and middle income country GDPs. All right, so you have these countries that are emerging from poverty, and they want to have a 2 or a 3 or a 4 or 5% GDP growth in a given year. Surgery can represent negative 2%. That's something that I think a minister of health would pay attention to, as would they the $12 trillion return potentially on investment. This is another interesting bit of research that Tiffany Chow did. There's a lot of talk about cost effectiveness, all right, and surgery is not being cost effective. Well, these are some medical treatments here in terms of dollars per DALY averted, and these are surgical conditions in terms of dollars per DALY, and you see that they're all on the same graph. It's not as if surgery is off to your right and all the medicine things are off to your left. So A, surgery is truly cost effective, but B, it's a little bit of a false argument because you need surgery for NCDs. You need surgery for every part of healthcare delivery, so it's really almost a false argument. This economies of scale argument, I think, is very important. So cost effectiveness arguments miss that, all right? What's important is, as what I mentioned before, that once you make those initial outlays and you have a system that can provide this, you have tremendous economies of scale and scope. And this is something that Haile DeBaas showed back in 2006. Instead of looking at an individual procedure, they looked at the platform, the district level platform, and found that it is highly cost effective once you've made those investments at the platform level. Let's talk about financing. Well, that's a big black box for a reason, in that we looked at 958 national health accounts between 96 and 2010, and only Georgia and Kyrgyzstan had explicitly defined their surgical expenditures. How can you possibly manage something if you don't, A, you don't know your financial inputs, and B, you don't know your clinical outputs? There's also this issue with different types of payers, people paying for different aspects of surgical care. And the other concept we talked about in the Finance and Economics Working Group is the one of risk pooling or prepayment. And Gavin's going to talk to you more about this. But bottom line is, surgery very often is time critical and unpredictable. No one saves for their femur fracture. They don't know that's coming. And the user fees, as I mentioned before, are extremely expensive. Sometimes they can be 2-3 times GDP. Information management. This is some work that Sarah Greenberg did. She pulled all of these databases and queried them and said, okay, in these databases, let's look for these words, these terms, surgery, burn, wound, cesarean, and you can see 01, 02, et cetera. But then look over here and you see all this data on these other things. It goes back to the point I made before. If you're not measuring your inputs and you're not measuring your outputs, highly unlikely you're going to have a good idea of what's really going on in your system. So that is why we, based on Jim Kim's directive and Richard Horton's, we came up with 6 indicators that fall under 3 categories. One, roughly preparedness, delivery, and impact. The first is an access metric. So what percentage of your population is within 2 hours of a facility that can provide those bellwether procedures? Second, how many providers do you have? How many surgeons, anesthesiologists, and obstetricians per 100,000 do you have? Next is a very simple one. How many procedures are you doing in a given year? And then what's the mortality after those procedures? And then last, these have to do with financial risk protection. So what's the financial impact of the care you're providing? Because you can do a great job at ramping up care. If you're not paying attention to this, as I've shown you before, it can actually be impoverishing. In each section, you will see recommendations, national, international organizations, ministries of health, et cetera. And then another thing that I think is very important, and I'm going to talk about this a little bit now and a little bit at the end of the day, is this concept of a national surgical plan, which really breaks down that chart that I just showed you, discusses infrastructure, workforce, service delivery, financing, and information management, and what things might a Ministry of Health think about in scaling up between now and 2030. So in our report, obviously, we came up with some broad suggestions and recommendations, but every country is going to be a little bit different. One of the exciting things is at our last meeting, Emmanuel Macasa, who many of you know, raised his hand in the middle of the meeting and said, I've just been in contact with my government, and we would like to work with you to implement the findings of the Lancet Commission and the indicators. It's a wonderful opportunity to pilot this, and at the end of the day, I'm going to show you, we put a team together, and in the last month, actually, have enough data. We can show you most of the indicators and what they look like now for Zambia. So I think it's going to be really helpful, and it will give their Ministry of Health some really granular information on what, in each indicator, how they are, where they sit in relationship to other countries. So with that, thank you for listening to that introductory overview. I want to talk to you briefly about the rest of the day. This is, primarily you're going to see a discussion of the high-income response today. We're going to have a number of other launches, and certainly there will be different emphases, but if you're wondering, it's just because of the regional nature of this meeting and because of the people in this region and the colleges that we have here. That's the purpose for today. We have a busy schedule. We're going to try to keep to a pretty tight panel structure, 5-minute intro, and then keep to time here because we have a lot of ground to cover today. So thank you very much.